Welcome to the Texas Medical Association's Distance Learning Center. Timely, convenient, and affordable education from TMA, your trusted source for practice and professional needs. And now, the audio portion of our program.
Our next speaker is Mary Jo Malone. She's the Executive Vice President and CEO of the Physicians Advocacy Institute out of Chicago, Illinois. Now, Ms. Malone's career includes more than 19 years of professional experience both at the federal and state government and medical association work. She's also served as the Director of Federal Affairs for the AMA's Washington, D.C. office and Vice President of Private Sector Advocacy, and in those roles I had the opportunity to work with Mary Jo, and so we're looking forward for her interesting discussion about I already provide quality care, don't I? So Mary Jo.
Okay, can everybody hear me? Okay. It's usually not a problem. Good morning, everyone. It's very nice to be here, and it's very nice to have worked with physicians during my professional career. You're great to represent, and I think you all know that your TMA staff serves you extremely well, and it has always been a pleasure to work with them. Before I start, I'm going to kind of give you an overview of what's going on out there in the country in terms of the federal government, in terms of state government, business and consumer thinking, and kind of what's been driving this quality measurement and efficiency measurement and ranking and rating and basically determining where you fit in relation to your peers that's been going on for about the last decade and actually been gaining momentum. So, okay, next slide. Oh, okay, Q&A. I provide quality care already, don't I? This is my answer. Probably you do. But this is really your takeaway from today. No one cares. No one really cares whether you do or not. There's different gradations of how different sectors care whether you do or not. But this is a strong personal opinion, having worked in this area for years. You look at whether or not you're providing quality care totally different than insurers do, the business community does, consumer groups do, and you really need to understand that you have to wage this battle on two fronts, which I'll get into. Okay, you all know this and you've heard it for the last 5 years. How did we get where we are? Well, healthcare costs have been skyrocketing, out of control. Premiums continue to just be totally not even related to inflation. Patient outcomes, this is really important, are not any better. And you can go to any source you want, but all the money we spend gets us no better health outcomes. There's overuse, underuse, misuse. Those are the big terms being used. And a health confidence survey in 2010 showed that individual consumer dissatisfaction with the healthcare system is really totally related to cost. It's not so much related at all to whether or not they like you or they like what you're doing. It's really the cost factor. In 2009, we were at 17.6% of GDP. The graph on the bottom is actually only goes up to 2005, but you get the drift and you see where the whole thing's drifting. And everyone, it's part of the discussion from the last session about Medicare costs being out of control. It's part of this whole cost that's driving this whole Medicare debate about do we privatize Medicare, do we go to some type of a voucher system for Medicare. It's because the costs, the entitlement programs, Medicare, Medicaid, are just bankrupting us. And it's been that focus on the cost. It was also a focus during the whole health system reform debate about could we, over the next decade, bring down health care costs. And that's why you saw the debate in the Affordable Care Act that actually continues. Hasn't been resolved. Okay, now, I'm a little disappointed with this kind of dull slide here. I had this great graphic that had all of the, the listing of the 36 countries there with their little flag, and it was all colorful, and I was going to just keep scrolling through slide after slide after slide to show you that Japan ranked first in terms of life expectancy at birth, and the United States is down at the bottom at 36, tied with Cuba. So this is another graphic that gets used all the time to prove that we're spending more money than anyone else in the whole world, and we're getting absolutely no better outcome. Here are two IOM reports that were issued in the last decade, and these two reports really did more to get us where we are than anything else. And I don't know if you remember, I remember it really well, and I know Dr. Rohack remembers it really well. The first report, To Err is Human, Building a Safer Health System, I don't know if you remember, but that report said that there were 98,000 preventable deaths in this country from medical errors. Well, I'm going to tell you, organized medicine went nuts over that number. And there were two schools of thought. One, the number probably is higher and we need to get on board. And the other half said, you know, this is outrageous. We need to prove that's wrong. We have the best healthcare system in the country. And actually, organized medicine spent a lot of money, a lot of it, trying to debunk that report. Well, in a sign of the times, and I really think a sign that shows how this whole debate's evolved, we no longer, I mean, people now would probably just think you're ridiculous that you ever even argued with that 98,000 preventable death figure. It's more than that, and we're pouring billions of dollars into preventing, you know, readmissions to hospitals and acquired infections in hospitals. I mean, everyone knows a hospital's a really unsafe place to go. That's what everybody talks about now. But in 2000, I mean, that was not the debate. So that report really, really moved things along and got us kind of where we are today. As I said, today there's widespread acceptance to reduce errors. HHS just announced a $1 billion campaign to reduce medical errors. And by that they mean prevent readmissions. I mean, you're going to hear all of the stuff about preventing readmissions. You're going to get paid to prevent readmissions and hospital-acquired conditions. The AMA is in this coalition that was announced to reduce medical errors, a number of specialty societies. So obviously, if you think back to what we were discussing in 2000 and what we're discussing today, it's been quite the pendulum swing. Okay. Here's what happened. Because those skyrocketing costs were out of control and there were no better health outcomes, you get government, you get business, you get consumers, you get private payers. Every one of those interest groups is driving a different part of the debate to get us to measure quality and to measure something. You can measure quality, you can measure performance, you can measure efficiency, you can measure a combination of all of them. And not only, it started out initially they were just going to measure it, but then, of course, that didn't take long, that they were going to link paying to all of those things. So that's kind of where we are now, and you, unfortunately, are caught up in the middle of this. So it's been driven by a number of sectors in the country, some private, some public. Okay, we've got the federal government. I could spend a whole session on just this physician quality reporting system. You've got the federal government through Medicare pushing this PQRS that used to be PQRI. Probably get some more initials before we're done. You've got Hospital Compare, which has gone on for several years as HHS, CMS has tried to rank hospitals, and they've actually gotten pretty far with this. The hospitals basically don't like it because, of course, just like everything else the federal government does, there's a lot of problems with the methodology. But again, as I said to begin with, it doesn't matter. No one cares if what they're putting out is inaccurate. I'm going to talk about that. We're at the point where people just want things out there and you know, forget whether it's accurate or not, and that's why we have to work as hard as we can to make it as accurate as we can. There's going to be a physician compare website, and it's going to do the same thing the Hospital Compare site did, and right now there already was an article in AM News about how inaccurate the physician compare site is, and it isn't even really up. All it is right now is a physician, they took the CMS physician directory site and moved it over to this physician compare site. But it is going to get to be, it's going to evolve into a a physician compare. It's going to compare you. There will be some type of a ranking or a rating system based on all of this data that's analyzed about you. And that's where I'm headed with all this. Then, of course, you know, there's various local websites and report cards and patient ways to get on the web and write remarks about you. I went onto the web recently to look up a doctor that I was going to go to, and I was appalled at what just popped up about this doctor from, you know, several patients just writing in, and it's up there. And it wasn't flattering. I mean, it didn't affect my decision, but that's what you're up against. Okay. This is the what's good for hospitals is good for doctors. First they attacked hospitals, and so now they're going to take everything they required of the hospitals and did to the hospitals, and they're going to do it to you. Here was a headline. This was just announced in April, that Medicare will begin basing hospital payments on patient satisfaction surveys. Now, Medicare has been publishing patient satisfaction scores on the Hospital Compare website, but now they're going to use it to adjust payments. So if your patients aren't happy with how long they wait or what kind of a mood your receptionist was in that day, you know, it's going to affect your payment. Under value-based purchasing, you're going to hear a lot of that term in the coming years, value-based purchasing. And again, as an aside, that's in the eyes of the beholder, but Medicare is going to begin withholding 1% of hospital payments beginning in 2012. And that withhold for everybody is going to go into a bonus pool if you get a score that's above average on both quality indicators and on patient satisfaction. So patient satisfaction is now getting moved into the whole combining patient satisfaction with quality. And I'll tell you, if you've been in a hospital recently, the hospital survey, your patient satisfaction survey from the hospital, is at your house before you get home from the hospital. I mean, and they dog you. They keep mailing them to you till you fill them out. And the thought occurred to me that, you know, I've never been in a physician's office where they've asked me to fill out a patient satisfaction survey or mailed me one. So you may want to think about that, how in touch you are with how satisfied your patients are. Okay, how physicians are measured accurately or not. All right, I think that first bullet's worth reading. I don't like to read off the slideshow, but in today's data-driven environment, even physicians who are not participating in pay-for-performance or incentive programs are faced with profiling and rating processes by payers that use administrative data to make determinations on physician performance. So the point here you all need to take away is, even if you don't think you're providing data and being graded or rated or whatever, it's happening. Private payers are so sophisticated at this with all of their computer systems. I mean, they know everything about you and every claim you've filed and can, you know, do anything they want to get whatever information they want. We can fight over the methodology of measuring physicians, and believe me, there's been a lot of fights about the methodology, reports after reports and studies after studies. But my view is that the battle over that is lost on the physician front. It's going to happen. It's happening. And to argue over the methodology may get you, you know, a little movement here or a little movement there, but it's happening. It's here. And those who measure physicians do not consider accuracy critical. I can't tell you how many meetings I've been at where that's what they get up and say. All right, don't let the perfect be the enemy of the good. Again, if I had $1 for every time I've heard that from a business leader or a consumer or someone who wants to measure you, I wouldn't have to be standing here today. I'd be in Mexico. So accuracy, they understand it isn't perfect. They understand that in terms of efficiency ratings, that the attribution of which physician does what and who gets the bulk of the episode assigned to them could be wrong. But they just keep saying, if we don't start somewhere, we're never going to get anywhere. So that's my political take on kind of where we are. Oh, there we go. Sorry. Okay, here's a headline from Health Leaders that was just at the end of March. Physician quality ratings are imperfect, but a start. The gist of that article was what I just indicated. And this has been happening throughout the country. A number of state medical associations have sued private payers, or in some cases the state government that's initiating some of these quality rating programs. In California, the California Medical Association sued, and just recently a judge there threw out the lawsuit from CMA on the basis that the Blue Cross Blue Shield rating program that gave doctors a blue ribbon, or didn't give you a blue ribbon, was flawed due to the methodology. The judge threw it out saying, I mean, this is a whole new line of attack, and once this one judge rules this, you can expect it everywhere. There's probably a party at the Blue Cross Blue Shield Association, that these rating programs are protected speech under the First Amendment. Now, I mean, really, that just kind of does blow your mind, but now we've gotten to the point where the health insurers are, have protected speech to say whatever they want about you. So that's not a good development. Okay, what I really want you to take away today is the importance of claims data. Claims data is what is driving everything that's being done to judge you, to rate you, to rank you, to determine where you fit, what you're up to, what's going on. As a unit of analysis. Now, their claims data doesn't give the insurers everything they want. You're missing clinical data. Everyone knows the shortcomings of claims data, but again, that doesn't matter. But if you take claims data combined with the clinical data, you've really got a treasure trove in terms of running analysis on you, the physician, individually and as a member of a group practice. So you've got claims data, which is driving everything. And if you take anything out of this room today, and I know Lacey's going to talk a little bit about this, maybe a lot, claims data will determine your fate. And so it's really critical that you code correctly, that you understand what your top codes are, that you're coding accurately. Again, this gets into the whole ascribing, attribution, when you're determining episodes of treatment and what physician's responsible, how that's all going to work. And the claims data is going to get better and better because we're going to have ICD-10 with hundreds of thousands of more descriptors of what you're doing and whether or not you're doing it correctly. So claims data is really going to determine your future. See how I'm doing on time. Okay. I just want to briefly, really briefly, show you what's going on nationally in terms of what's happening and how entities are understanding the importance of pooling national claims data from across the country. Because when you think about it, if Blue Cross of Texas just pools its Texas physicians, it's just got Texas physicians. But if all of the private payers in the country pool all of their data, their claims data, they can really much more definitively stand up and defend what they're doing, because the N is billions and billions of claims. And some of you probably are as old as I am and remember Carl Sagan with his billions and billions of stars. Well, this is billions and billions of claims. So there's something that was funded in the Recovery Act that is going to allow the federal government, CMS already awarded a contract to the physician-favored Ingenix, to set up this multi-payer claims database. And it's going to have billions of claims in it, and the insurers have wanted this for years. my view is that the insurers actually got this written into that act. And what a lot of physician organizations are afraid of here is that this information is going to be used for fraud and abuse activities. And that's one of the main goals in all of these claims databases, and I'm going to tell you what Senator Cornyn's up to in a minute here on that regard. But they want to use all the private payer claims data, Medicare and Medicaid, and use it to determine ratings, rankings, determine who's most cost effective. And whether or not, I mean, if you think you don't like your rating, if you're just being judged against Texas physicians, think about the billions and billions of claims based on certain CPT codes, and they will have the I'm having problems with this microphone. They'll have the bell-shaped curve of all bell-shaped curves. You're not going to stand a chance. So this is what's going on with that database. I think you may have heard something about this FAIR database, which was established by edict, basically in agreement with Attorney General Cuomo in New York, and it's basically to fix the flawed Ingenix database on determining UCR, and that's just up and starting, but they're going to have a lot of data too. There's something that you can see, this is a trend. The Office of Personnel Management now is going to pool all of its claims from all of the federal health benefit plans. So again, more billions and billions of claims out there. Okay, now we get to the holy grail of claims payment data. And this has actually been going on since 1979. I think it's about to get resolved, and it's not going to get resolved the way we want it to. In 1979, efforts began that have continued for people outside of government, for anyone, private payers, citizens, to get their hands on the Medicare claims database, to look at what physicians are charging for what and how it compares across the country. And again, when I say billions and billions, there's billions and billions and billions of claims here with Medicare. And there have been several court challenges, and a court ruling has held since 1979 that, in fact, that claims data is protected under your patient confidentiality agreement, and the federal government cannot release that claims data information. That's held up until the present. And there was another court ruling recently that said they did need to open it up. The Wall Street Journal sued because they were doing an article and they wanted to see that, and their article was, it was a fraud and abuse article. So just in April, Senator Wyden and Grassley introduced a bill to open up that database, and again, their interest primarily is fraud and abuse. The private payers want the data, to run it with their data, and to have a, the world's biggest and best data warehouse. Also, just within the last week or two more bills have been introduced to open up this information, to give it to the public. One from Senator Durbin of Illinois and one from your very own Senator Cornyn. So if there's any of you that can talk to him about some of the problems with this, I'm sure TMA knows all about that. I'm just briefly going to touch on what 2 state governments are doing, which have really moved this along. In Wisconsin, and again, Wisconsin is as Jeff Goldsmith mentioned, kind of a weird anomaly because they have so many, basically it's a group practice model in the state, but nevertheless, they have this Wisconsin Collaborative for Healthcare Quality and this Wisconsin Health Information Organization, and basically it was driven by business and the state government, and they basically pooled all of the claims data, including Medicaid data. So they have data on practically every insured and uninsured person in Wisconsin. And they've applied that data and use it for episode of treatment groupers with the goal has been, it hasn't happened yet, to provide a public ranking system of physicians that, any citizen can go on a website and see where their physician ranks across quality and efficiency, cost and quality. And again, the Wisconsin, 5 minutes. The Wisconsin Medical Society actually participated in this, and they found, while they complained mightily throughout the process about all the flaws with it, this is one upside for them. They found that they now, because they're in this consortium and they have access to the data, they can run queries and run data for themselves, which actually can give them information that can counter the insurer's information using the same data. So that, one way to look at this is the insurer's data can also become our data. And you can really, prove a lot of things you want to prove if you've got the data set. The Massachusetts Group Insurance Commission had a physician profiling and network tiering plan. The goal with tiering is to get the patients to pay more if they go to a doctor that isn't ranked as being a quality doctor. Massachusetts Medical sued and actually worked with the state for years, and that's still kind of tied up in court, but the state government's doing it. Okay. My message is don't despair. There's health plan and databases. The health plan databases will never know what you know about your patients. And what you've got to do is, and I know the speakers following me are going to talk about all of these things, but you don't need an EMR. It's probably a good idea, but you can do a patient registry that gives you as much information about who your high-risk patients are, who's consuming the most resources, and that's the kind of information you need to be able to argue against the insurers. Let's see. Okay, I'm going to sum it up here. I am going. There are a number of steps you can take to get control of the information out there, and you really can't afford to wait any longer. What I've got here at the end, just to show you, and I can talk about this later, is the Physicians Advocacy Institute has built a claims data warehouse that's for physicians, for you to be in control of your claims data, for you to know whether or not you're being paid correctly. And I could give you a 45-minute presentation just on that, but I wanted you to know there is somebody out there trying to help you with this stuff. And in conclusion, I just want to read to you a quote here. This week's, the May 9th issue of AM News, and the business section has a great article, just happened on the plane. I went, oh, maybe I should look at AM News before I give this little talk. And here's the headline, What Your Data Can Tell You. I mean, what are the chances? I was so excited. It says, even a practice that isn't participating in these programs can use analytics to get a solid, fact-based snapshot of how it is performing. Analytics can show physicians how similar chronic care patients are faring, or show common threads among patients, or even help a practice identify expansion opportunities. The ultimate goal, seeing the forest of your patient population through the trees of your individual appointments. So I'll end it with that and thank AM News and thank.
This concludes our program. Questions? Contact the TMA Knowledge Center at 1-800-880-7955. Thank you for using the TMA Distance Learning Center.